Maintaining oxygenation, ventilation, and a preserved intact airway is a core part of your practice. With the advent of video laryngoscopy, endotracheal intubation has gotten a lot easier, but things can still go wrong. Whether you're an anesthesiologist, an emergency physician, or a paramedic, if your patient can't breathe, nothing else matters. Maintaining oxygenation, ventilation, and the preservation of a protected airway is a core part of your practice, and you have to be great. With the advent of video laryngoscopy, endotracheal intubation got a lot easier. At the Medical Simulation Center, we recently acquired what I call our Hyperrealistic Airway, and for the first time, we can demonstrate some of the subtle but critical challenges that can prevent endotracheal intubation and demonstrate how to overcome them. In addition, in this video, we use the TrueCore head, which is easier for beginners. Novice intubators, as well as experienced airway experts intubating a newborn or a patient with distorted landmarks, will often be presented with a view like this. The critical cognitive realization that the airway operator must make at this moment is you have no idea where you are. If you are lost in a sea of pink, you do not know whether you are too deep or too shallow or too far to the left or too far to the right or too much crike pressure or too little. And this is okay. You must pull out slowly until you find a landmark you recognize before you continue the procedure. Ideally, you will see the epiglottis, but even finding the uvula or the tongue is an improvement over this view. Remember, the epiglottis is literally attached to the base of the tongue, so there's nothing wrong with visualizing the tongue. Keep pulling back until you either see a structure you recognize or you see teeth. Check your pulse ox and begin again. Your instinct, which is both futile and dangerous, is instead of pulling back, you lift harder, potentially lacerating the tongue or worse, and rarely improving your view. Worse yet, since most of the time you are lost in a sea of pink, it is because you are too deep. If you lift hard enough, you can create a view of the lumen like this, and in the stress of the moment, pass the tube directly into the esophagus. Don't be that guy. Instead, pull out, find a structure you recognize, and then slowly advance 1 centimeter at a time until you can find the epiglottis. The next attempt is a novice move. However, really physically strong airway operators can continue to have success with this poor technique for some time until they encounter a difficult airway where no amount of brute strength will make up for this error. This is one of two poor techniques I see being used when a provider says, "I'm just not strong enough to intubate." When the epiglottis is visualized, the operator freezes because they don't want to lose the view of the epiglottis, and they know the larynx must be right behind the epiglottis, and the natural instinct is to heave up on the tongue. If you pull hard enough, this may work, but it is essentially the same as lifting a person off the bed by their tongue. The mistake is the blade has not been advanced into the vallecula. By simply advancing the blade into the vallecula, the epiglottis is much easier to lift out of the way, and often only a few ounces of pressure directly into the vallecula will make the epiglottis flip up and out of the way.